Good morning, dear students. Today's topic of lecture, acute kidney failure and acute liver failure. Let's start with kidneys. Kidney functions in human body. Excretion of metabolic waste products and foreign chemicals, regulation of water electrolyte balance, acid-base balance, and extracellular fluid osmolarity, regulation of arterial blood pressure, secretion, metabolism, and excretion of hormones, and gluconeogenesis. I think you remember the anatomy of kidneys and the urinary system. Kidneys are supplied with arterial blood through the renal artery. Kidneys are only organs that have two capillary beds. The first one is glomerular capillaries, and the second one is peritubular capillaries. There are two types of nephrons. Nephron is a functional unit of kidneys. So each kidney in the human contains about 1 million nephrons, each capable of forming urine. The kidney cannot regenerate new nephrons, therefore with renal injury, disease, or normal aging, there is a gradual decrease in nephron number. After age 40 years, the number of functioning nephrons usually decreases about 10% every 10 years. This loss is not life-threatening because adaptive changes in the remaining nephrons allow them to excrete the proper amounts of water electrolytes and waste products. There are two types of nephrons, juxtamedullary nephrons and cortical nephrons. What is the difference between them? Juxtamedullary nephrons has a long loop of Henle, and it's conducted by capillary types, as it's called vasa recta. It's for concentration of urine, and this loop of Henle of juxtamedullary nephrons are located deeply in medullary layer. Cortical nephrons has a short loop of Henle. There is no vasa recta, and they only a short distance deep into the medullary layer. And the proportion of two types of nephrons can define the concentrating ability of nephrons, kidneys. So in human kidney, 20–30% of nephrons are juxtamedullary type, so we can concentrate urine up to 1,200 and 1,400 milliosmoles per liter. Some desert animals, such as Australian hopping mouse, has about 85% of juxtamedullary nephrons and only 15% of cortical nephrons. And its urine concentration up to 10,000 milliosmol per liter. 20% of plasma flowing through the glomerular capillaries is filtrated in the Bowman space, and the glomerular filtration rate is about 120 milliliters per minute normally, and the amount of such filtrate per 24 hours is 180 liters. Urine formation results from glomerular filtration, tubular reabsorption, and tubular secretion rate. And the renal handling of substances can be several types. There are main 4 types. Type 1. There is filtration process, but no reabsorption and no secretion. So excreted volume of such substances are equal to filtration rate. It's actual for creatinine. Excuse me. That's why we use creatinine clearance rate to evaluate the glomerular filtration rate. Next, type B. There is filtration and partial reabsorption, but no secretion. So the amount of excreted such substances, it's a difference between filtration and reabsorption. Such type is characteristic for main electrolytes. Type C, there is filtration and all filtrated substance completely reabsorbed. So no excretion, no secretion. Such type of renal handling is characteristic for amino acids and glucose. That's why in healthy state in urine such substances are absent. And finally, type D. There is filtration, no reabsorption, but there is present secretion. So excreted amount of such substances, it's filtration plus secretion. This type is characteristic for organic acids and bases. Here you can see filterability of solutes that is inversely related to their size. Such big molecules as albumin has very poor filterability. Now, summary of forces causing filtration by the glomerular capillaries for healthy humans. Glomerular hydrostatic pressure, it's about 60 millimeters of mercury column. It allows filtration, but two forces that act in opposite direction. It's a glomerular colloid osmotic pressure. It's about 32 millimeters of mercury column. And Bowman's capsular pressure. It's about 18 millimeters of mercury column. So resulting net filtration pressure is about 10 millimeters of mercury column. Here you can see the juxtaglomerular apparatus. It includes macula densa, specialized epithelial cells in distal tubuli. And near this macula densa, it's located juxtaglomerular cells of arterial wall of afferent and efferent arterioli. So this apparatus plays important role in regulating arterial pressure through the secretion of hormone renin. You remember from the last hour lecture the role of renin-angiotensin-aldosterone system in regulating blood pressure and circulating blood volume. On the next slides, you can see different parts of nephron and which substances are reabsorbed and which substances are secreted in this region. This one is proximal tubuli. Loop of Henle has descending CIN part and ascending SIG part, and many substances, mainly electrolytes and bicarbonate, is reabsorbed in this region, and secreted is hydrogen ions. Also, you can see which diuretics act in this region and which way. This one is distal tubuli. There is reabsorption of main electrolytes in this region and begin to act antidiuretic hormone, reabsorbing the free water. Reabsorption of bicarbonate take place also, and secretion of hydrogen ions and partially potassium ions. And finally, collecting ducts. In collecting ducts, there are many channels that are sensitive to antidiuretic hormone, aquaporine channels. So reabsorption of free water takes place in this region, reabsorption of urea, bicarbonate also, and the secretion of hydrogen ions. This is a filtration, reabsorption, and excretion rates of different substances by the kidneys. You can see that glucose fully reabsorbed and bicarbonate almost fully, and main electrolytes reabsorption rate about 99%. Urea is reabsorbed by 50%. There is no reabsorption for creatinine. And many hormones take place in regulation of tubular reabsorption. You can see here site of action and effects of aldosterone, angiotensin II, antidiuretic hormone, atrial natriuretic peptide, and parathyroid hormone. You remember from the last hour lecture on water electrolyte balance the role of antidiuretic hormone in regulation of extracellular fluid osmolarity. There is osmotic signals and non-osmotic signals that can change the secretion of antidiuretic hormone in hypothalamus. Here you can see the classes of diuretics and their mechanisms of action and the tubular site of action. So, severe kidney diseases can be divided into two main categories. Acute renal failure, in which the kidneys abruptly stop working entirely or almost entirely, but may eventually recover nearly normal function, and the chronic renal failure, in which there is progressive loss of function of more and more nephrons that gradually decreases overall kidney function. Acute renal failure. Definition. Decreased glomerular filtration rate resulting in the accumulation of non-protein nitrogens and affected water electrolyte and acid-base balance. In 65–70% of cases of acute renal failure, there is oliguric or anuric phase stage. Oliguria, we say when urine output less than 500 ml per 24 hours, and oliguria when it's less than 50. Acute renal failure is diagnosed in 15–20% of patients in intensive care unit, and about 5% of those need renal replacement therapy, hemodialysis. Half of patients with septic shock need hemodialysis, and mortality rate in these patients about 60–80%. The mortality rate in acute renal failure, in isolated acute renal failure, it's 9%. When there is a dysfunction of two organs, half of patients die, and in dysfunction of three organs, no one survives. When the patient needs hemodialysis and mechanical ventilation at the same time, the mortality rate is 76%. And the patients with burns developing acute renal failure, mortality rate 70%. So you can see that acute renal failure is the most potent causes of mortality in intensive care unit. For grading the severity of acute kidney injury, it's used the classification by Acute Kidney Injury Network with abbreviation ACIN classification. According to this classification, there are three grades of acute kidney injury severity. Grade 1, it's based on the rate of increasing plasma creatinine level and urine output. Creatinine level is more dominant sign than urine output. So, grade 1, when creatinine is increased 1.5 up to 2 times compared to initial level, or increase to 0.3 milligram per deciliter, and urine output less than 0.5 ml per kg per hour during 6 hours. Grade 2, when creatinine is increased 2–3 times, and such diuresis lasts 12 hours. And grade 3, when creatinine is increased more than 3 times, and urine output 0.3 ml per kg per hour, or completely anuria. There are another classification, it's called RIFLEM. It's the first letters of these stages: risk, injury, failure, loss of function, and end-stage renal disease. Now you can see that 3 first grades. It's taken from the ACIN classification, and grade 1 is called risk of injury, grade 2 injury, acute kidney injury, and grade 3 acute kidney failure. And the last 2 grades, loss of function when renal function is absent during more than 4 weeks, and end-stage renal disease when patient needing dialysis more than 3 months. These 2 grades mainly for prognosing. The causes of acute renal failure can be divided into three main categories. Acute renal failure resulting from decreased blood supply to the kidneys. This condition is often referred to as prerenal acute renal failure to reflect the fact that the abnormality occurs in a system before the kidneys. This can be a consequence of heart failure with reduced cardiac output and low blood pressure, or conditions associated with diminished blood volume and low blood pressure, such as severe hemorrhage. The second one is intrarenal or renal acute renal failure, resulting from abnormalities within the kidney itself, including those that affect the blood vessels, glomeruli, or tubules. And the last one is post-renal acute renal failure, resulting from obstruction of the urinary collecting system anywhere from the calyces to the outflow from the bladder. About 55% of acute renal failure is prerenal origin. About 40% is renal, it is called infrarenal or parenchymatose, and post-renal causes in 5 to 15%. Some causes of prerenal acute renal failure. It's intravascular volume depression, cardiac failure, peripheral vasodilation and resultant hypotension, and primary renal hemodynamic abnormalities. Infrarenal or renal acute renal failure main causes are small vessel and glomerular injury, tubular epithelial injury, and renal interstitial injury. And post-renal acute renal failure may be due to bilateral obstruction of the ureters or renal pelvises caused by large stones or blood clots, bladder obstruction, or obstruction of the urethra. Physiologic effects of acute renal failure. A major physiologic effect of acute renal failure is retention in the blood and extracellular fluid of water, waste products of metabolism, and electrolytes. This can lead to water and salt overload, which in turn can lead to edema and hypertension. Excessive retention of potassium, however, is often a more serious threat to patients with acute renal failure because increase in plasma potassium concentration, hyperkalaemia, to more than about 8 milliequivalent per liter, it's only twice normal, can be fatal for patients. Because the kidneys are also unable to excrete sufficient hydrogen ions, patients with acute renal failure develop very often metabolic acidosis, which itself can lead to lethal or can aggravate the hyperkalaemia. You remember from the last lecture that in acidotic state, there is a shift of potassium from cells into plasma. In the most severe cases of acute renal failure, complete anuria occurs. The patient will die in 8 to 14 days unless kidney function is restored or unless an artificial kidney is used. Some causes of chronic renal failure. Metabolic disorders such as diabetes mellitus, obesity, amyloidosis, arterial hypertension, renal vascular disorders, immunologic disorders, some infections such as pyelonephritis, tuberculosis, primary tubular disorders due to neurotoxic medicaments and heavy metals, urinary tract obstruction in renal calculi formation, hypertrophy of prostate, urethral constriction, and congenital disorders such as polycystic disease, congenital absence of kidneys tissue. The most common causes of end-stage renal disease, it's mainly complication of diabetes mellitus and arterial hypertension. May be due to glomerulonephritis, polycystic kidney disease, and others. A decreased number of nephrons in both kidneys, when decrease level reach 500,000 in both kidneys, there is isosthenuria occurs, inability of the kidney to concentrate or dilute the urine. So Effect of kidney failure on extracellular fluid constituents. You can see increased level of non-protein nitrogens, potassium, water retention, sodium retention, retention of hydrogen ions, phenols, phosphates and sulfates, and a decreased level of bicarbonate. It's quite easy to diagnose post-renal acute renal failure, but we have some difficulties in differentiating between prerenal and renal acute renal failure. For this goal, you can use many indicators given in this table: urine specific gravity, urine osmolarity, sodium level, fractional excretion of sodium, chloride level, and the ratio in urine and plasma concentration of creatinine, osmolarity, blood urine nitrogen, and renal failure index. There is some formula for the calculation of such indices. Renal failure index, fractional excretion of sodium, laboratory markers in acute renal failure. The main marker used in routine clinical practice is creatinine. In Ukraine, laboratory gives in micromole per liter. In main European countries, for example, in milligram per deciliter, there is a conversion in one and the opposite side. Creatinine is formed from creatine in muscles, is released into the blood at a constant rate and is easily filtered by the glomeruli and not reabsorbed. The increase in creatinine requires its accumulation, so it does not immediately reflect the deterioration of renal function. And there are many extrarenal factors of influence on plasma creatinine level. Increasing factors are young age, male gender, increased muscle mass, increased consumption of meat products, JAFA reaction in ketoacidosis, hyperglycemia, and medicaments such as trimethoprim, cimetidine, and overexercising. Decreasing factors are following: older age, female gender, dietary protein restriction, vegetarianism, muscle loss, amputation, and JAFA reaction in hyperbilirubinemia. We use clearance of creatinine for estimating glomerular filtration rate. To determine the renal clearance of any substance, it's necessary to know the concentration of this substance in blood and in plasma, and urine, as well as the amount of urine excreted in 1 minute. Saying simply, what is the creatinine clearance rate? It's the amount of plasma, milliliters of plasma, that is completely cleared from creatinine during 1 minute. So there is correlation between the plasma concentration rate of creatinine and the clearance rate. And you can see the severity of renal dysfunction according to the rate of clearance of creatinine. The next marker is urea. Our laboratory give it in millimole per liter, European laboratories in milligram deciliter, and the conversion rate. In some cases, we use blood urea nitrogen. It's calculated according to this formula: plasma urea in milligram per deciliter divided to 2.14. Urea is a product of protein metabolism. Unlike creatinine, urea in high concentrations is a toxic substance. And there are also many extrarenal factors of influence on plasma urea. Increasing factors are following: hypovolemia, increased protein in the diet, severe catabolic conditions such as sepsis, fever, trauma, burns, gastrointestinal bleeding, corticosteroids, and tetracyclines. Decreasing factors are aggressive infusion therapy, diluting blood, pregnancy, dietary protein restriction, and liver pathology. Urea is synthesized from the ammonia in liver. There are many new laboratory markers in acute renal failure, they can use for diagnosing and estimating the severity of the process. Many private laboratories made such analyses. They may be quite expensive, but may be quite informative. So they are cystatin C, neutrophil gelatinase associated lipocholine, interleukin 18, and kidney injury molecular 1. But no of the markers of kidney injury are ideal. It's necessary to take into account all the data from anamnesis, clinical examination, laboratory data, instrumental methods, etc. Clinical signs of uremia. You can see different symptoms in many organs and systems, in nervous system, in cardiovascular system, respiratory, gastrointestinal tract, metabolic signs, in blood analysis, endocrine signs, even musculoskeletal and skin signs. There are 4 clinical stages of acute renal failure. Initial stage. It's several minutes up to several hours. It's time interval from the affecting factor begin to the first clinical or laboratory signs. The next stage is oliguric and anuric stage. It can last about 2-3 weeks. I mentioned above that in 30% of acute renal failure, this stage is absent. Oliguric stage is followed by polyuric stage due to the fact that filtration is restored earlier than the reabsorption process. It can last about a week. And last stage is restoration of renal function during 2 years of chronic renal failure formation. The main directions of acute renal failure prevention. It's adequate volemic therapy, normal blood pressure, tissue oxygenation, avoiding nephrotoxins and avoiding X-ray contrasts. There is limited possibility to treat, especially medicamentosely, acute renal failure. So main guidelines make accent on prevention. In anuric or oliguric stage, in hyperhydration, you can try to stimulate diuresis using loop diuretics. But maximum dose of furosemide recommended is 200 milligrams per day. If it's ineffective, you should suggest hemodialysis. The main dangerous sign of acute renal failure that can be fatal is hyperkalaemia. This is the recommendations of European Resuscitation Council for the management of patients in hyperkalaemia. So, in such patients, you can see here a severity of hyperkalemia rate, and all patients with suspected or detected hyperkalemia, you should provide ECG monitoring. If there is typical signs of hyperkalemia in ECG, it's peak T waves, broad QRS complexes, flat or absent P waves. You should protect head myocardium from the toxic effects of potassium using antagonist calcium. There is a dosage rates. Also, you can try to shift potassium into cells using insulin glucose and beta-2 adrenomimetics such as salbutamol. The main cause of kidney injury is using X-ray contrasts. So the big problem today in endovascular surgery, contrast-induced nephropathy. We can diagnose such situation on the basis of increased plasma creatinine to 25% compared to its initial level or up to 44 micromole per liter during 48 hours after administration of X-ray contrast. In pathogenesis of contrast-induced nephropathy, the main role play vasoconstriction in afferent arterioli, decreased glomerular filtration rate, hypoxia in renal tubules, and direct injury of tubular epithelium due to hyperosmolarity of X-ray contracts. Prophylaxis of CIN: decreased volume of X-ray contrast, decreased osmolarity. Modern contrast has normal or decreased osmolarity. Intra-arterial administration is more dangerous than intravenous, but way of administration is dependent on the procedure. Withdrawal of potentially nephrotoxic drugs during 2 days before and 3 days after the procedure. Correction of anemia and preventive hydration using normal saline or isotonic sodium bicarbonate solution. For estimation of risk of contrast-induced nephropathy, Mehran scale is used. All risk factors estimated in points. In our military hospital in Lviv, Dr. Yakimovich studied this problem. He compared estimated using Mehran scale incidence of contrast-induced nephropathy and the real incidence. And he showed that real incidence much more higher than estimated by Mehran scale. The next dangerous cause of acute kidney injury is rhabdomyolyses. Skeletal muscle destruction can lead to release of myoglobin into the blood when its level reach above the 1.5 milligram per deciliter. This can lead to myoglobinuria and acute renal failure. Increased plasma potassium in such cases can lead to arrhythmias, even cardiac arrest. The patient develop increased phosphorus, uric acid, creatinine phosphokinase, lactate dehydrogenase, and AST levels in plasma. And the creatinine phosphokinase has diagnostic value. When it reaches the level above the 5,000 units, it correlates with the risk of developing acute renal failure. Main causing factors of rhabdomyolysis well known are over-exercising in sport, but in such situation may be in asthma, delirium, and seizure, ischemic states, hyperthermia, including malignant hyperthermia, electrolyte disbalances, some addition from alcohol, cocaine, heroin. Many medicaments and infections can lead to rhabdomyolysis. Patient management in rhabdomyolysis. Fluid therapy with the aim to urine output 200 mL per hour. For this goal, we use normal saline in rate up to 1 liter per hour. And if it's ineffective, you can try to stimulate diuresis using loop diuretics or even osmodiuretics. The next strategy in rhabdomyolysis is urine alkalinization. Reduces the deposition of myoglobin in the renal tubules, they are damaged due to lipid peroxidation, and reduces vascular spasm. The aim of urine alkalinization is urine pH more than 6.5. For this goal, we use 1 liter of normal saline, 1 liter of half normal saline, and 1 liter of 5% dextrose, adding to each 100 millimole of sodium bicarbonate. But you should not use fluids containing potassium and lactate. Side effects of urine alkalinization, such as hypokalaemia and metabolic alkalosis, restrict its use. If it's ineffective during 4-6 hours, we should stop such treatment and suggest hemodialysis. In our anesthesiology practice, there are main factors that can lead to acute renal failure. Mainly, it's fluid therapy. volume, speed of administration of fluids, also type of fluids can lead to acute kidney injury. Many medicaments used in our practice are nephrotoxic. Also, surgery type and sepsis can lead to acute renal failure. Fluid overload can cause renal compartment syndrome, renal venostasis, and affected renal oxygenation. The kidneys are covered with fibrous fascia. It's called Gerard's fascia. So the increase in volume in them causes an increase in pressure and compartment syndrome with ischemia. Severe trauma, sepsis, major surgery can cause endothelial dysfunction, glycocalyx damage resulting in capillary leakage with interstitial edema. Renal perfusion pressure. It's the difference between the renal arterial pressure and renal venous pressure. And the renal perfusion pressure decreases in arterial hypotension and in venous hypertension. And if central venous pressure reach above the level 12 centimeters of water column, we should stop fluid therapy. Many fluids are nephrotoxic. Such side effects has all synthetic colloids, including hydroxyethyl starches, gelatins, dextrans, and crystalloid solutions, polyhydric alcohols such as sorbitol and xylitol. Nephrotoxicity of medicaments can be realized by direct tubular toxicity, glomerular vasoconstrictive effect, allergic interstitial nephritis, urine crystallization. All these mechanisms of nephrotoxicity can cause acute kidney injury. Tubular toxicity and glomerular vasoconstriction can cause acute kidney injury without initial oliguria and may be initially asymptomatic. All these things complicate diagnosis. Nephrotoxicity of medicaments were studied in this investigation with the abbreviation is NINDA. The study included pediatric non-severe in-hospital patients who was given more than 3 medicaments from this list of nephrotoxic medicaments simultaneously or aminoglycoside for more than 3 days. And during the first year, 25% of these patients developed acute kidney injury. What about adult patients? Many of them are treated with triple HAMI, inhibitors of angiotensin-converting enzyme, diuretics, and non-steroid anti-inflammatory drugs. The combination of 2 or 3 of them very often lead to acute kidney injury. What about intensive care units? Medicaments are causing factors of 25% of acute kidney injury in intensive care unit. 20% of top 100 medicaments in adult intensive care units are nephrotoxins. Medicaments are number 1 and number 2 among all causes of acute kidney injury in pediatric intensive care units. Even newborns are treated with 25 medicaments in average in intensive care units, more than half of them being nephrotoxic. What to do with all these problems? During the study NINDA, that lasted 3 years, the administration of nephrotoxic medicaments decreased to 38%. The incidence of acute kidney injury decreased to 64%. Maybe you should start barking about this problem. We must make diagnosis of acute kidney injury in case of increasing plasma creatinine to 0.5 mg per deciliter during 48 hours on the basis of treatment with nephrotoxic medicament, and suggest to stop or reducing the dose in such cases. Of course, renal replacement therapy or hemodialysis is the only effective method of treatment of acute kidney failure. Indications for renal replacement therapy are following: fluid overload, hyperkalaemia, metabolic acidosis, poisoning, uraemia, increase in uremia without specific manifestations, and indications for urgent hemodialysis. Urea level in plasma more than 36 millimole per liter, uremic syndrome developing encephalopathy, pericarditis, hemorrhagic diathesis, hyperkalaemia more than 6 millimole per liter with typical ECG signs, acidosis with arterial pH less than 7.1, oliguria, urine output less than 200 ml per day or anuria, and hyperhydration resistant to diuretics. The big authority in this field is Italian professor Claudio Ronco. He made indications lists for hemodialysis that include, except above mentioned indications, there are some other ones. For example, blood urea nitrogen more than 13 millimole per liter, dysnatremia, sodium level in plasma less than 115 or more than 160 can be quickly corrected in hemodialysis. Hyperthermia, multi-organ dysfunction, and systemic inflammatory syndrome are also indications for renal replacement therapy. Hemodialysis is based on the process of diffusion and osmosis. Due to concentration difference on both sides of semi-permeable membrane, if solute substances diffuse, it's called diffusion. When solvent diffuse, it's called osmosis. On one side of semi-permeable membrane, blood flows, on the other side, dialysate fluid. We can also, using the hemodialysis, extract the excess of water from the body. It's called ultrafiltration. And applying suction to dialysate fluid, we can provide convection process. It's increase the effectiveness of cleansing toxic substances. And in such cases, the patient can develop hypovolemia, so replacement fluid can be used for restoring circulating blood volume. What is needed for renal replacement therapy? First of all, adequate vascular access. Apparatus, it's called artificial kidney, dialysate fluid, anticoagulant, heparin, to avoid clotting in tubes, replacement fluid, and medical staff. In chronic cases, hemodialysis can be provided by nurses, but in urgent hemodialysis, the state of patient is usually severe, so it needs to be present a doctor. Main abbreviations of continuous venous hemodialysis, hemofiltration, hemodiafiltration. It's schematically shown continuous venous hemodialysis and which substances are extracted. Hemofiltration allows to eliminate toxic substances with low and moderate molecular weight. And hemodiafiltration. Principles of dialysis with an artificial kidney. The apparatus looks like such this. The blood is extracted from the body and flows in dialyzing camera. This one is called artificial kidney. There is very many small tubes. Inside the tubes, blood flows, and outside the tubes, in the camera, dialyzing fluid. Then blood is returned to the body. At this moment, we should add anticoagulant, and in many stages present, there are detectors of pressure and bubble trap. This is a comparison of dialyzing fluid with normal plasma and uremic plasma. Due to difference in concentration, many toxic agents are extracted from the blood. In hemodialysis, it's mainly small molecular substances. You need central venous access for urgent dialysis, and the catheter looks like such this. Red marked port is for extraction of blood, and the blue marked port for returning the blood. Peritoneal dialysis. We can use peritoneum as semi-permeable membrane washing with dialyzing fluid abdominal cavity. This is a dialysate for peritoneal dialysis. In children, peritoneal dialysis is recommended as first-line therapy in acute kidney injury. Dialysis can lead to many complications. You can see signs of complications in nervous system, cardiovascular system, in lungs, gastrointestinal tract, in blood analysis, metabolic signs, musculoskeletal signs, and some infections can develop too. Only renal transplantation can survive the patient with severe cases of chronic renal failure, but waiting list for appropriate donor is quite long. 1 year survival after renal transplantation reach 97%. But the patients having transplant are given potent immunosuppressive therapy during all life to avoid rejection of transplant. Signs of early rejection are fever, hypertension, and graft pain. The second part of our lecture about acute hepatic liver failure. I hope you remember that liver is included into splanchnic circulation. The liver functions in human body. It's filtration and storage of blood, hemopoiesis in the fetus, metabolism of carbohydrates, proteins, fats, hormones, and foreign chemicals, formation and secretion of bile and lymph. Half of lymph is formed in liver. Storage of vitamins, iron, and cuprum. Formation of coagulation factors. 11 among 15 clotting factors are synthesized in liver. Filtration of bacteria, degradation of toxins, lactate metabolism, metabolism of bilirubin, and elimination of medicaments are also liver functions. Splanchnic circulation. Liver is supplied with blood from the hepatic artery and portal vein. Portal vein gives blood, venous blood from all gastrointestinal tract and the spleen. The liver is the largest organ in the human body, contributing about 2% of the total body weight, or about 1.5 kg in the average adult human. The liver consists of two lobes, right lobe being larger than left one. The liver consumes 20% of oxygen from the body's total consumption. The basic functional unit of the liver is the liver lobula, which is a cylindrical structure several millimeters in length and up to 2 millimeters in diameter. The human liver contains 50,000 to 100,000 individual lobules. This is a schematically shown liver lobula. So hepatic artery and portal vein supply liver sinusoids with blood. Liver sinusoids are hepatic capillaries. In the wall of such sinusoids there is epithelial cells, Kupffer cells, macrophages, and stellate cells. There is space of this where is lymph is formed, and then it flows to lymphatic duct to return to venous system. and the two liver cell plates between them bile canuculi, where bile is produced and collected in bile duct and flows into the duodenum. So sinusoids look like not as typical capillaries. Blood cleaned in sinusoids is collected in central veins. Central veins empty into the hepatic vein and hepatic vein into the vena cava inferior. Regulation of blood flow through the sinusoids provided under the influence of endothelin and nitrous oxide produced from epithelial cells and stellate cells, the wall of sinusoids. Hepatic blood flow. The liver has high blood flow and low vascular resistance. About 1 liter 50 milliliters of blood flows from the portal vein into the liver sinusoids each minute, and an additional 300 milliliters flows into the sinusoids from the hepatic artery. So total averaging about 1,350 milliliters per minute. This amounts to 27% of the resting cardiac output. The portal vein and hepatic artery supply the liver with oxygen, each 50%. The pressure in the portal vein leading into the liver, it's average about 7-9 millimeters of mercury column, and the pressure in the hepatic vein leading from the liver into the vena cava normally average almost exactly 0. This small pressure difference, about 9 millimeters of mercury column, shows that the resistance to blood flow through the hepatic sinusoids is normally very low, especially when one considers that about 1,350 mL of blood flows by this route each minute. Cirrhosis of the liver greatly increases resistance of blood flow, and high hepatic vascular pressures can cause fluid transudation into the abdominal cavity from the liver and portal capillaries, we call ascites. The liver possesses a remarkable ability to restore itself after significant hepatic tissue loss from either partial hepatectomy or acute liver injury, as long as the injury is uncomplicated by viral infection or inflammation. Partial hepatectomy, in which up to 70% of the liver is removed, causes the remaining lobes to enlarge and restore the liver to its original size. The regeneration is remarkably rapid and requires only 5 to 7 days in rats. In patients, about 1-3 months. During liver regeneration, hepatocytes are estimated to replicate once or twice, and after the original size and the volume of the liver are achieved, the hepatocytes revert to their usual quiescent state. The liver plays a big role in bilirubin metabolism. Normal ranges of bilirubin in blood, total bilirubin, our laboratory give it in micromole per liter, European laboratories in milligram deciliter. It's a conversion in one and another side. Up to 17 micromole per liter total bilirubin, free bilirubin, non-conjugated or non-direct, it's called. It's 75% from total bilirubin and up to 13 micromole per liter in plasma. Conjugated direct bilirubin up to 4 micromole per liter. In newborns, there is increased level of bilirubin due to fetal hemoglobin destroying. This is a differential diagnosis between hemolytic jaundice, parenchymatose jaundice, and cholestasis jaundice. So, definition of acute hepatic failure. What you need to make the diagnosis of acute liver failure: encephalopathy, coagulopathy, jaundice, and initially normal hepatic function. Survival rate of patients with acute liver failure increases significantly from 1917s. It's the data from King's College Hospital of London. If survival rate in 1917s was about 15%, or today it reached about 60-70%. It may be due to hepatic transplantation. All classifications of severity of hepatic failure use the time interval from jaundice to encephalopathy. The classical King's classification of acute hepatic failure: superacute, when time interval from jaundice to encephalopathy less than 7 days, mortality rate 64%. It's mainly paracetamol poisoning, ischemia, viral hepatitis, and toxins. Acute hepatic failure. The time interval from jaundice to encephalopathy 8 to 28 days, and subacute when this time interval is 5 to 26 weeks. What you need for formal diagnosing of acute hepatic failure: coagulopathy that can be detected as prothrombin time prolonged to 6 seconds, or international normalized ratio more than 1.5. Development of encephalopathy in patients without cirrhosis and the prolongation of disease less than 6 months. Etiology of acute hepatic failure. Main viruses can lead to this situation. It's not only hepatic viruses A, B, C, D, E. It also can be cytomegalovirus, seronegative hepatitis, reaching 25% in Great Britain. Many medicaments. On the first place, it's paracetamol poisoning. And this drug can cause dose-dependent toxicity for liver. Another drugs can provide idiosyncrasy. These drugs are anti-tuberculose drugs, statins, narcotics, NSAIDs, and anti-epileptics. Toxins: carbon tetrachloride and amanita-phalloides. Many vascular diseases, such as ischemic hepatitis, hepatic vein occlusion, Body-Chiari syndrome, and heat shock, and many others. You can see the incidence of causing factors in acute liver failure that demonstrates that 39% of acute liver failure caused by paracetamol, 13% caused by medicaments through idiosyncrasy, so more than half of acute liver failure due to medicaments. Laboratory tests. AST and ALT, these enzymes get into the blood due to damage of hepatocytes. However, their plasma level does not always correlate with the degree of necrosis of hepatocytes on biopsy. A rapid decrease in the level of these enzymes may be due not to recovery, but to massive death and reduction in the number of living hepatocytes. Rapid increase in transaminases is characteristic of the acute phase of viral hepatitis, ischemia, and drug-induced liver damage. Alkaline phosphatase is characteristic for cholestatic states. Prothrombin time, expressed by the international normalized ratio, is an indirect indicator of the concentration and activity of coagulation factors. Bilirubin is of great diagnostic and prognostic value. You mentioned normal ranges, and jaundice is present at the level of plasma bilirubin more than 50 micromole per liter. Hepatorenal syndrome. It may be some connecting point of two parts of this lecture. Acute renal failure develops in 50-80% of acute hepatic failure. Hepatorenal syndrome is a separate type of injury that manifests itself in severe liver failure with ascites, most often in alcoholic cirrhosis. The cause is considered to be renal vasospasm leading to decreased glomerular filtration rate, maybe also infectious complications in the abdominal cavity in patients with hepatic failure. Hepatorenal syndrome can disappear on the basis of liquidation of infection with antibiotics. There are main criteria for diagnosing hepatorenal syndrome listed here, and the additional criteria, diagnostic criteria of hepatorenal syndrome. Clinically, it's divided into two types, hepatorenal syndrome. Type 1, when creatinine levels increase rapidly to high level over the period of up 2 weeks with multi-organ dysfunction, and type 2, when creatinine level stays stable and occurs only with ascites. Treatment options of hepatorenal syndrome. First-line therapy is vasopressin. Also, albumin can be used, and renal replacement therapy. It's used in patients awaiting liver transplantation and in cases where it's possible to improve liver function. The prognosis is unfavorable, especially for type 1. Half of patients die within a month, and 20% over the next 6 months. Hepatic encephalopathy. The main pathogenetic point for developing hepatic encephalopathy is toxic effects of ammonia. Normally, ammonia is converted to urea in the liver. Scales of severity of hepatic encephalopathy. There are 4 degrees. The first one is affected concentration of attention. The second, disorientation, incomprehensible speech, agitation. Stage 3 is significant drowsiness, and 4 is coma. Treatment options of hepatic encephalopathy include reducing of nitrogenous components production in the intestine by using laxatives and antibiotics. Also, you can use lavage of intestine. Ornithine aspartate is also used for treatment of hepatic encephalopathy. It provides a substrate for the cycle of urea synthesis from ammonia and glutamine synthesis. And other options are flumazenil and bromocriptine. Patients with hepatic encephalopathy need adequate nutrition. During the first 2 days, we administer glucose solutions intravenously and no enteral nutrition. After this, you can add gradually proteins. Hypernitrogenemia can lead to increased glutamine production in astrocytes, increasing osmolarity in neurons and water shift intracells that can lead to edema. So ammonia astrocytes, benzodiazepine receptors, and N-methyl D-aspartate receptors, resulting in oxidative stress, releasing to TNF-alpha, interleukins 1, beta, and 6. All these things can lead to brain edema in hepatic encephalopathy. Treatment options of brain edema is carried out on a general basis, but we should be aware of coagulopathy in these patients, which can lead to intracranial hemorrhages. If osmodiuretics are ineffective, maybe use the therapeutic hypothermia with internal temperature at the level of 32-34 centigrade. Coagulopathy and acute hepatic failure. Causing factors. Affected synthesis of coagulation factors, pseudofibrinogenemia, improper fibrinogen synthesis, pathological polymerization of fibrin monomers, thrombocytopenia on the background of hypersplenism. Treatment options include vitamin K, fresh frozen plasma, and in severe cases, maybe Nova-7. Hypoglycemia in acute hepatic failure is observed in 80 up to 100% of cases of encephalopathies. really in liver tumors occurs due to decreased glycogen synthesis. Another possible reason may be slowdown in insulin metabolism. For the assessment of liver damage severity in cirrhosis, mainly use child-Turcotte-Pugh score. This scale scores encephalopathy severity, prothrombin index, bilirubin level, albumin level in plasma, and severity of ascites. And the patients are divided into three classes: A with number of points 5, 6, B 7, 9 points, and class C with 10, 15 points. Here you can see 1 and 2 years survival in classes A, B, and C. The management of patients with hepatic cirrhosis in class A and B, surgical treatment can be considered, but in class C there is high risk of surgery, especially in patients with bleeding from varicose, esophageal, or gastric veins. It's preferable conservative treatment or minimal invasive procedures. Recommendations for management of bleeding from esophagus, depending on the level of resources of healthcare. Gold standards are ligation plus intravenous therapy with vasoactive drugs such as octreotide and terlipressin. But depending on the healthcare levels, in normal healthcare resources may be used ligation. In medium resources, sclerotherapy can be considered, and in low-income countries, mainly used balloon therapy. The management of patients with refractory ascites includes, in big volume ascites, evacuation via the laparocentesis and albumin infusion. Supportive therapy can include diet with salt restriction in patients with hyponatremia, fluid restriction. Only hepatic transplantation can survive the patient with severe hepatic failure. It's the only effective method. Survival after the liver transplantation during the first year reached 90%, and during the 5 years, 70%. It's the recommendations, British recommendations for referral or discussion with the liver transplant unit when it's the patient needs transplantation. Separate scales for paracetamol-induced acute liver failure and non-paracetamol-induced acute liver failure. There are another methods for treatment of acute liver failure. It's called MARS, molecular absorbent recirculating system. It's dialysis using 20% albumin as dialysate fluid. It removes toxins, both water-soluble and bound to albumin, allows patients to survive before transplantation, but very expensive method that requires a lot of albumin. It looks like this in practice. Thank you for your attention.